The next speaker is Dr. Peter Eastwood. His topic is very interesting, imaging of the human upper airway using optical coherence tomography. We've heard about him in the morning, but for those who have not heard about him, he is a senior research fellow at the Western Australian Sleep Disorder Research Institute in the School of Human Biology, University of Western Australia, and he's been awarded for the Astra Australian Lung Foundation Fellowship in Respiratory Medicine. Dr. Peter Eastwood.
Thank you very much. I'd like to, I introduced this topic very briefly earlier on, my talk earlier on today, but I'd like to provide a bit more details about how it works and how it could potentially be used in the setting of diagnostic sleep. So, this is a very quick summary of the different imaging modalities that we currently use in the upper airway, including fibre optic endoscopy. There are limitations, pluses and minuses of all of them. Endoscopy is intrusive. It's very, very hard with fibre optic endoscopy to get any numbers out of it. It's very hard to draw a cross-sectional area. It can be done if you've got a reference sample, a reference point in there, but it's a real challenge to get numbers out of it. CT, we know it's got ionising radiation. MRI, I've never seen so many impressive pictures of dynamic MRIs at this meeting, and I think it's absolutely fantastic technique, and I'd like to know more about that, perhaps in question time, about how you actually get these measurements and get these people to sleep in MRI machines. I think that's got incredible potential as a diagnostic tool. Acoustic reflection we heard a bit about this morning. It's been around for a long time and it's never really taken off as a way to assess upper airway dimensions, although it's being used more widely in the nasal cavity. So this is a very simplified diagram of what this optical coherence tomography is all about. Essentially, there's a broadband light source which provides light into this splitter. One half of the light source goes this direction, one half goes the other direction. So there's this bit that goes to a reference beam. This is actually a mirror which spins up and down and slants, and the reflection from that beam goes back down to this point here. The other half of the light source goes to the sample, in this case the airway wall, and the reflection is again combined with this reference reflection to get processed into a measurement of what is the light is being bounced off. And importantly, because it's light, it does penetrate the mucosal surface, and you can get reflections of subsurface structures up to about 1 millimetre under the surface of the mucosa. So this is it. This is called anatomical optical coherence tomography, something we developed a number of years ago. The catheter, the outer catheter, is placed inside an outer catheter here, which is translucent, and the optical probe, it sits inside here. This outer catheter is about 2 millimetres out of diameter, and we can rotate that probe at about 2.5 cycles per second. You can see from this is the kind of image that we obtain. Again, this is where the catheter is sitting. This is the outer wall of the catheter, the inner wall of the catheter, and this is a measurement of the velopharynx. This is the soft palate back here, posterior pharyngeal walls, lateral pharyngeal walls. So we can measure things like cross-sectional area of the airway very accurately. We can measure AP dimensions and lateral dimensions. And the interesting thing is all this blurriness that you see here, that's actually a measurable image. You can reconstruct that and look at subsurface images. And a lot of the ophthalmology techniques now are using this OCT in the retina to look at subsurface structures. And you can get down, the resolution, because it's light, the resolution can be extraordinarily high, up to 2 to 12 micrometers. Although for our purpose, we're interested in the air-mucosal interface. So this is anatomical optical coherence tomography in the upper airway. We feed down the external catheter to position that in the esophagus, and then we put the other probe, the optical probe, inside that. And once it's inside the outer probe, we can pull it forwards and backwards in the upper airway. So here's an example of the optical probe sitting at the level of the esophagus. And this image at the bottom here is just the esophagus wrapped around the catheter itself. This is moving the probe up to the level of the hypopharynx, and again here we see the posterior wall, the sides of the wall, and this will be the back of the epiglottis here in this image. We can pull it up a bit higher into the oropharynx, and we see that characteristic shape of the oropharynx. We can pull it up even higher into the nasopharynx or the velopharynx. We can see that characteristic shape that I spoke about earlier, where we see the posterior pharyngeal wall, the anterior pharyngeal wall, so it's like a sausage lying on the side. Very rarely do we see an anterior-posteriorly orientated velopharynx. So currently the specifications of the system are that the probe is 1.3 millimetres outer diameter, the outer probe is about 2 millimetres, and it's exquisitely sensitive because it's relying on measuring the reflected light off that mucosal surface, and only about 10 to -6 power of that light is actually being reflected back, so it has to be incredibly sensitive, rotating at about 2.6 hertz, and it can range from about 26 to 36 millimetres, and we can translate the probe up and down automatically at about 0.2 millimetres per second, when we call that a pullback scan. This is an example from one of our publications in the American Journal of Respiratory Critical Care Medicine in 2006 of a pullback scan where we popped the catheter or the probe down into the esophagus, and we slowly pulled it back all the way through the hypo, oro and velopharynx, and you can see along those lengths there the characteristic structures. And this is an anterior-posterior view, and this is a lateral view. So at this point here, the catheter is in the esophagus, and you can see that it's just wrapped around it. We pull it up a bit higher. This point here, we move it, and it's in the hypopharynx. You can see that's the back of the epiglottis here, and this is the lateral view, oropharynx. We pop into the nasopharynx here, and upper nasopharynx there. So with this kind of a system, it's also possible to it's a bit like a helical CT scan, where you can reconstruct this whole system to give you a three-dimensional image. And most importantly, the imaging can be done during sleep, continuously during sleep, during apneas and during hypopneas. I've shown you this data before. The thinking for many years was that the individuals with sleep apnea had an airway which was orientated like that. So the AP dimension, the longest AP dimension was in the AP, which meant that given lateral collapse is a very common occurrence in people with sleep apnea, they were more susceptible to lateral pharyngeal collapse because of their airway shape. And as I said earlier on this morning, we've done lots of scans. In this example, 21 healthy normal individuals and 32 individuals with a range of severities of sleep apnea. And we just don't see that AP-orientated velopharynx. We certainly see a smaller velopharynx in people with sleep apnea, but we don't see an AP-orientated one. And that's just some examples of the kind of shapes of the velopharynxes that we find. This is just an example. This is putting some numbers now to all the individuals that we have scanned and looking at the ratio of the anterior, posterior to lateral dimensions, where if the airway was a circle, the ratio would be 1. If the airway is an AP-orientated ellipse, the ratio would be 2. And if it was a lateral-orientated ellipse, the ratio would be 0.5. We can see that with all the controls, which are down here, the ratio is well below 1. But then also are the patients with sleep apnea. And that's just making the point that whether you measure the shape of the airway during inspiration or during expiration, that's the shape of the airway that we see. The other point is that the cross-sectional area of the airway is consistently smaller in patients with sleep apnea. It increases with CPAP, but the shape doesn't particularly change. And of course, I showed you earlier on today what happens to the airway when we change from a supine position to a lateral position. That is, the airway becomes more circular in the lateral position than it does supine, perhaps giving it some rigidity and prevention for collapse. So in summary, we have this new system which this was developed a while ago, and there's a few American companies now which are thinking about taking this on. It's being used quite a lot in the esophagus for things like Barrett's esophagus, where it's put in the esophagus and it's spun around and it's looking at subsurface structures. We hope that some of these companies will take it on and say, hey, perhaps we can do some of this surface imaging in the upper airway for measurement of airway function during sleep. It has a high-speed operation and resolution capacity. It can scan at a range sufficient to capture the entire airway, and we can capture full circumferential profiles at about 2.5 hertz It does have some advantages in that it, over other scanning systems, in that it has a very low intensity light that it uses, and it's non-ionising radiation. I'm not sure if I agree with the relatively low cost. It's quite an expensive machine, but it is very portable, so you can take it to patients' bedsides. There are a number of potential applications for this. Measurements of airway shape, size and volume, as I showed you. Perhaps we can use this to define the site and mechanisms of upper airway obstruction, but most importantly, do that during sleep. Do it during different stages of sleep, do it during different head postures, do it during different body postures as well. And use that information to guide tailored surgical treatments afterwards. And perhaps we can use awakening measurements to predict severity of sleep apnea and the site of upper airway collapse during sleep, a bit like the drug-induced sleep endoscopy. It's essentially a modified awake manoeuvre, but it looks like it has quite good predictive value, particularly if you get those BIS levels right for working out what's happening with the airway during sleep. And of course, any hollow organ you can put a probe into, this system can be used, for example, in the urological setting, the respiratory medicine, the ENT setting, and gastroenterology. And I'll stop there. Thank you very much.
Thank you, Dr. Peter. The next speaker is Dr. Vikas Agarwal. But I just want to emphasize that there is a speaker after him too. Dr. Rajkumar will be the last speaker of this session.
Okay. Good afternoon. When Vijay called me up to speak on sleep study, I told him it will be better if a chest physician who regularly does a complete polysomnography to explain on that. But he said, no, it's a ENT surgeon crowd, and you are supposed to give a functional understanding of how ENT surgeons should proceed with a sleep study and how to go ahead of that. So I'll try to, in next 15 minutes, I'll try to give you an overview of how a sleep study should be approached by an ENT surgeon. So generally, it's not that you did a sleep study and that's end of the story, you send the patient for CPAP. In fact, sleep study, polysomnography in whatever levels, 1, 2, 3 we'll discuss, is only an starting point for the ENT surgeons, because sleep study is the foundation of all the buildings that we are going to form, medically or surgically. Since we are surgeons, we'll definitely think surgically, but sleep study is the foundation of what we are going to make on that. Before that, we have to understand that sleep apnea is only one of the 83 sleep disorders or more which a person comes with. Once he knows that you are doing sleep work, he will come with all other restless leg syndrome, as was discussed in great detail, insomnia, parasomnias, various other things. So we cannot obviously deal with all those things in as good detail as we can with sleep apnea. And sleep apnea is only one of the 83. And even in sleep apnea, there is central sleep apnea and obstructive sleep apnea. Central sleep apnea, the pathology does not lie in the ENT domain. It lies in the brain. The brain forgets to send impulse to breathe. Therefore, the person stops breathing. So you have to give a CPAP. Like we give a hearing aid in the sensory neural hearing loss. Surgically, we cannot reverse a sensory neural hearing loss, but obstructive sleep apnea. Can I have the sound, please? Can I have the sound, Jack? Obstructive sleep apnea is a condition in which the sleep is disturbed because, sound, Jack, because the airway is obstructed in the throat, palate, tongue, both. Yes, it's okay, no problem. Since the obstruction can be in the nose, palate or tongue region, we are talking of obstructive sleep apnea, and if the obstruction is in any of these regions, this is the domain of ENT surgeons, and no other than an ENT surgeon can do justice to this obstruction. So if there's an obstruction which is causing a traffic jam, so what is the most logical solution to this problem? Squeezing through or employ your equipments, clear the obstruction and get the highway free. Play it again. Obstruction causing traffic jam. Most logical solution is definitely not squeezing through. If we can clear, let's clear the obstruction and get the highway free. If we cannot do it, obviously, then we give the patient a control so that the life can move on. But if we can, we should try for a cure, because control does not go well with most of the patients. Around 70% is the statistics. They just refuse to take it. They are uncomfortable with it. So at least in the selected non-obese, normal-looking people who are having all the symptoms of obstructive sleep apnea and snoring, let's try to give a cure and not just a control. So can we cure? How to diagnose whether he has a problem worth cure or control? So which study should we advise? We have already discussed about that. Just for beginners, a repetition that a level 1 polysomnography is with all the channels, at least 7 as Vijay stated, with all the parameters from the brain, leg, orbits, everywhere in the hospital is level 1, which is attended by a qualified technician. If the same thing is done at home, that's called level 2. And if you do only a cardiopulmonary study, whether in the hospital or at home, it's called level 3. So that does not have the channels from the EMG, EEG, EOG, etc. It only has the cardiopulmonary parameters. So when do we advise what? If we are not sure that the patient is suffering from a group of problems called sleep-related breathing disorder, the constellation or the OSA, upper airway resistance syndrome, everything is included into sleep-related breathing disorder. If the sleep is getting disturbed because of breathing, or if the breathing is getting disturbed only during sleep, if we are not sure about that, and we may suspect that the patient can have parasomnias, restless leg syndrome, narcolepsy, etc., we are bound to, or we must advise a level 1 polysomnography. But if the patient definitely has a history supportive of SRBD, that means if the patient's spouse or the bed partner is very sure that he starts snoring heavily, and then he stops breathing, and then he takes a gasp, or he gets up, he has to sit and sleep. If you have a witnessed apnea, along with the history suggestive of clinical history suggestive of OSA, then possibly we can get away with a level 3 study. So whether we do level 1 or level 3, what are we looking at? What is the index we get? And is that enough to cure a patient? We get most important index called the AHI. So what is AHI? Apnea Hypopnea Index. What is apnea? More than 10 seconds if there is a cessation of breathing. And hypopnea, which is more than 40% reduction of the airflow, if associated with a desaturation. If person stops his breathing for 10 seconds but does not desaturate, that's not apnea. Breath holding spells are possible. So if it is associated with desaturation, more than 10 seconds of apnea, and hypopnea, more than 40% reduction in the airflow, is one event. Problem is, if we calculate number of events in an hour, it tells us the severity of the problem, but not the cause. So if I have a problem in my knee, I'm asked to climb 5 floors. If I can climb 5, I'm fine. If I can climb only 4, I have a mild problem. 3, moderate. 2, severe. 1, very severe. That's severity, but that does not tell me that where is the problem in my knee. Is it osteoarthritis, tubercular arthritis, rheumatoid arthritis, or what? So AHI gives us the severity, not the cause. That is one thing has to be understood. And it has a lot of limitations. In upper airway resistance syndrome, it's false negative. The AHI will be normal, but the patient will have all the symptoms of OSA. That's called upper airway resistance syndrome. Since the time is limited, I cannot go into the details of that. Another limitation of AHI is that it does not give any idea about the site of obstruction or the structures causing obstruction. Whether this event is happening because of the palate, is because of the base tongue, because of the epiglottis, it does not tell us anything about that. It does not give even prediction about difficulty in intubation. If you are going to operate this patient, whether a high AHI patient will be difficult to intubate, it's not necessary. A patient with a 35 AHI can be much more difficult to intubate and to operate than a patient with a 80 AHI. Why? Because that depends on the site of the problem. If a patient has only a palatal collapse and giving a AHI of 70 or 80, you put a nasal airway, beautifully you can ventilate the patient and intubate. If the patient is having a huge base tongue, even with AHI of 30, 35, the moment you induce, the whole thing will fall and anesthetist will not be able to see anything. So AHI, again, severe AHI does not mean that the patient is a difficult intubation case. Then it does not tell us whether apneas are more or hypopneas are more. Though apneas are definitely more dangerous than hypopneas. I'll give you an example. Now, this patient you can see is into apnea. There's no airway. Patient is into apnea, and after 10, 12, 15 seconds, he'll start breathing, and that will be one event. That will be counted as one event. Okay? So this patient desaturated a little, 5% or whatever, and he stopped breathing for 10, 15 seconds, so this was one event. This patient huge base tongue, but able to breathe because he is young. Because he is young, he has got strong muscles to pull, he is able to breathe, epiglottis and base tongue, but since he is able to breathe, he is able to take the air in, it's not an event. He is badly stressed, desaturated also, but it's not an event. So that is one limitation of AHI. Another limitation is that even an apnea of 40 second, 50 second with almost 50% desaturation will be counted equally as a hypopnea of 10 second with just, sorry, I don't know why it's running on its own. Apnea of a long duration with great desaturation will counted equally, will get equal weightage on this scale as a simple hypopnea of 10 seconds with a 4%, 5% desaturation. Now this patient, if you see here, you can see it's obstructive. He is trying to breathe, but it's not opening up. Now the desaturation will start. See, I'll let this video play because it's a very, very important video to see. There's no breathing till this time. It's more than 10 seconds already. Now the desaturation has started. Just a little air went inside, but the desaturation is continuing. Now this apnea was, now this is counted as 2 because there's a little air gone. But you can see that the desaturation is still happening. This much little air was not enough. You can see that the saturation, now he has taken a deep breath. Too deep. See the saturation. 30. So even falling dangerously to dangerous levels of desaturation, the events are counted equal to as 4%, 5% desaturation. So that is again one thing which is very, but do we have a choice? No, we do not have a better choice. So we have to continue with it till we get a better choice. I have no other choice but to trust you. That's all I can do at this point of time. It's certainly going to change in coming years. So we get AHI, less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. Everybody knows about that. So what do we do next? At least it tells us where in this spectrum the patient fits. So what is the spectrum? Simple snoring, to upper airway resistance syndrome, to moderate, mild OSA, moderate OSA, severe OSA, and obesity hypoventilation syndrome or the Pickwickian syndrome. At least we get some idea where the patient is fitting on the spectrum. We should look for the LSAT or the lowest saturation, because while doing sleep endoscopy, we know that the patient in a normal sleep always goes till 65, so we are not bothered at least till 65. He will handle it easily. Below that we have to look for. And anyway, it gives the idea about the pressure in his system. More important is the time spent below 90% saturation, because that is more clinically correlating to the damage that is happening to his heart and the vasculature. Then we can look for the RERAs, which are suggestive of upper airway resistance syndrome, and position in which he gets apnea, as was earlier discussed, that supine gets more. So what should we do? Should we straight away go to a CPAP, or we do ENT examination? Obviously, we should try to look for obstruction if we can remove that. Obviously, weight reduction, lifestyle changes go without saying, nothing against that. What is important is that obstructions are of two types, static and dynamic. This is a very, very important concept, because static you can easily identify. Nose, huge tonsils, bad deviated septum, turbinate. Seema has already spoken beautifully that every person has to get operated in the nose if it is contributing. Dynamic obstructions are only present during, sir, can I get 2 more minutes?